Hello, everybody. Thank you for joining on Tuesday. I see a lot of people that joined our readings this past week. It's really good to see everybody. Um, this is part of our Women in Medicine series. I'm going to hand it off to Ankita Sagar, who's our co-chair of our Early Careers group, and she's going to just say a couple of words.
Thanks, Dr. Lee. Welcome, everybody. It is my absolute pleasure to invite you guys into an evening discussing women in medicine and topics that are near and dear to our hearts. So I do want to give a special acknowledgement that September is Women in Medicine Month. So I hope each of us takes a moment to congratulate ourselves for all the wonderful things that we have achieved in our lives. Even if that's as simple as not spilling coffee on yourself before you walk in the door. That's an achievement most days. But also because we are definitely excited to honor each of you as a woman in medicine, as well as allies for women in medicine and allyship. So thank you so much for joining us. And this is part 4 of our series. And we are very, very thrilled that we've had great success so far, and we hope to continue this conversation and highlighting and amplifying women in medicine and our allies. So I'll hand it over to you, Dr. Lee.
Thank you, Dr. Sagar. And likewise, I think that this has been a really fun project to do with Dr. Sagar, and just getting to meet all of our speakers who are amplifying the message of the importance of women in medicine. And thank you to all of you for joining and participating. I'm the governor for Long Island, and it was Ankita and I had this dream of starting this project, and she has been my partner in this, and it's been a pleasure to be a part of this group. It's my pleasure to introduce some very special speakers tonight who will be talking about 2 important topics that are so appropriate at this time. The first topic will be about burnout of women in medicine. And our second topic will be about the importance of peer support for women in medicine. Our first speaker, who many of you know is a member of our chapter, is Dr. Connie Newman. She is an endocrinologist. She's an adjunct professor at NYU School of Medicine. She is the founder of a group that I'm a member of called Wellesley Women in Medicine. It has about 2,000 members at this time. And through this, she's mentored numerous undergraduate students, medical students, residents, fellows, attendings, including myself. She's a past president of AMWA, and she continues to be a leader there. Her career has crossed every avenue in medicine, including scientific research, clinical medicine, what else can I say? Medical education and writing. She's made significant contributions to cardiovascular medicine and is known for her work about the safety of statins. She's a sought-after speaker who writes and lectures on topics that are relevant to women in medicine, including burnout, challenges of being a woman in medicine, sexual harassment. She's the author of many papers that about the inequities of women in medicine and what we face as women in medicine. And throughout her career, what I love about her is she's been an advocate for women in medicine as well as for the underserved. And we're very lucky to have her with us tonight. Our second speaker is equally as accomplished, and we're very fortunate to have Stephanie Catanese here with us tonight. She's reporting from the great state of Rhode Island. So she is we're going to adopt her in NYACP. She's an accomplished medical educator. She's an assistant professor at the Brown University School of Medicine, where she's in the associate program director of the internal medicine residency program. She is a medical educator extraordinaire on both the outpatient and inpatient services. And she's known nationally for her work on medical education, professional development, and mentorship. She serves as the ACP Wellbeing Champion for Rhode Island and is the 2020 winner of the Department of Medicine Beckwith Family Award for Outstanding Teaching. And she recently authored a paper published on the benefits of peer mentorship, and she's going to share her experience about that and what she's done at Brown. So I welcome her. So now I'm going to ask Dr. Newman if she could share her screen, and we'll start off with the burnout and women in medicine.
Okay, thank you very much for that kind introduction. Okay, let's see. Can you see my slides?
Yes.
No?
Yes.
Yes,
Sure.
beautiful.
Just a picture of me. Okay, so I want to thank Dr. Sagar and Dr. Lee for inviting me to speak today. And I want to thank Karen Tucker-Labello for arranging all of this. And my topic is burnout in women doctors. And I'm also going to talk a little bit about improving and maintaining wellness. I have no disclosures. So during this presentation, what I will do is discuss the definition of burnout and how prevalent it is in doctors. I will assess the risk of burnout in women doctors and talk about factors that have a greater impact in women compared to men. And then I'm going to hopefully have some time to describe ways to improve and maintain wellness. So first, I'm going to start with a case. I'm going to read the case, and then we will have a poll. So the case is of a female doctor who works in a large multi-specialty practice. She sees the same number of patients as her colleagues, but she admits to a close friend that she began doubting her skills as an internist during her residency, and she worries that she's not as competent as she should be at this stage in her career. This troubles her. She has some difficulty falling asleep. She occasionally feels sad, but not very often. She has some anxiety about her children, ages 7 and 9, and wants to spend more time with them. She reports that her weight has been stable in the past year. So which of the following is most consistent with this scenario? 1 is perfectionism, 2, depression, 3, burnout, 4, imposter syndrome, and 5, compassion fatigue. So perhaps we can have the poll. Karen?
Yes, I'm sorry.
We do it.
I apologize. Hang on a second.
Gives everyone more chance to think about the answer.
Right. All right. Hang on. Is it up now? It's on
No.
like you can't see it. Okay.
I can't see it. I'm sorry.
Okay. Maybe you could have attendees put in the chat box because
It's just not, it worked before. Okay. They'll think,
I'm trying.
I don't want to spend too much time on this, so.
Maybe perhaps folks can just put in
Type
the
in what
chat.
you feel.
Well, why don't you think about it, and we'll address it later since we don't have a poll. We'll go over the answer later. Oops. So what is burnout? Well, burnout has been defined as a triad of symptoms, emotional exhaustion, depersonalization, and a sense of low professional efficacy or accomplishment. This can be measured by a variety of inventories, but one of the early ones was the Maslach Burnout Inventory, known as the MBI. And the other surveys are listed here. They include a short form of the MBI, the Copenhagen Inventory, which I use on some studies that we're doing, the Stanford Professional Fulfillment Index, and the Oldenburg Inventory. And these surveys are meant to be used not personally, but for trials or surveys. So the key feature of burnout is that constant overtaxing reduces the ability to meet demands, whether they're physical demands or psychological demands, This can be a work or at home, and this will lead to disengagement. I guess we all know about adverse effects of burnout. For the doctor, it can be losing sleep, depression, sometimes suicidal ideation in extreme circumstances, poor self-care, family problems, and sometimes quitting medicine. For the patient, a burned out doctor may result in suboptimal care, errors in diagnosis or treatment, and reduced satisfaction with the doctor. And in the healthcare system, burnout can lead to staff turnover and reduced quality of care. So in this slide, I've summarized 5 studies which looked at burnout in physicians, and they disaggregated the results by women and men. That's not always done. And I just want to refer to the middle column, which says response rate. So what we see here is that the highest response rate was 56%. So although these surveys give us an estimate, perhaps an estimate of the number of physicians burned out, we really don't know what the other 50% would have answered. So they're not totally accurate, but nevertheless, what these studies found is that in women, 26 to 60% suffer from burnout, and in men, 21% to 42%. So the rate of burnout was higher in women compared to men. Medscape recently published a report on national physician burnout and suicide. And I just want to go over this report. They surveyed about 12,000 physicians who were members of Medscape. They surveyed them last year. Now, these results are only applicable to these particular physicians who were Medscape members. I looked it up to see how many active US physicians we have, and I found that in 2019, the number was around 600,000. So in the Medscape survey, 37% of those surveyed were women and 61% were men, and the 40% were younger than 50 years of age. So they found a higher rate of burnout in women physicians. 51% of women physicians reported burnout, and 36% of the male physicians. They also looked at burnout by specialty, but I'm not sure about these data at all, and that because we don't have the number of people in the specialty. The highest rate of burnout was in this particular survey was reported to be in critical care, and for internal medicine, the number was 46%. And factors related to burnout have been discussed in many articles in the literature, particularly by Tate Shanafelt and colleagues. And burnout can relate to excessive workload and job demands, loss of control and flexibility in work, difficulty integrating work and life, lack of social support, lack of community in work, loss of meaning in work, organizational culture and values that conflict with your own, and poor resources. So in this Medscape survey, and this is my last slide on it, the contributing factor, the factor that contributed most to burnout was too many bureaucratic tasks. 58% reported that. Other factors that were high up were spending too many hours at work, lack of respect from administrators, employers, colleagues, or staff, and insufficient compensation and reimbursement was reported as a contributing factor by 32% of those surveyed. So what I'd like to turn to is factors affecting burnout that are more impactful in women than men. And they are shown on this slide. I'm going to read them out. Imposter syndrome, higher standards, gendered bias and gendered expectations, slower career advancement, the dual role of being a doctor and a mother or caregiver, discrimination against pregnancy and breastfeeding, lack of female mentors, depression, compassion fatigue, and sexual harassment. I'm only going to be able to talk about a few of these factors that impact women more than men. So imposter syndrome, that was the answer to the case. The doctor thought she was a fraud, wasn't good enough to be a doctor. She had a lot of feelings of self-doubt. This has been studied and in small numbers and found to occur in medical students in more females than males. And also there was a study in family medicine residents showing that although 90% reported adequate training, 41% of women and 24% of men reported to have the diagnosis or the phenomenon, it's not really a diagnosis, of imposter syndrome. Gender bias can be implicit or unconscious or explicit. And I just want to point out that it's my view that this dates back thousands of years because of expectations of women as being at home, of being caregivers, and of men being outside, being working, and being leaders. And I'm showing you data in this table from 2 studies, which were done about 20 years apart. And they surprisingly showed similar similar rates of gender bias, a personal experience of gender bias, and even perception of gender bias. The first study was done in 1995 in faculty of 24 medical schools, about 2,000, and 60% of the women faculty, compared to 9% of the men, said they had a personal experience of gender bias. In the 2014 study of career development awardees, about 1,000, again, the numbers were similar to what we've seen in 1995. 66% of women and 4% of men reported personal experience of gender bias. Career advancement can be a problem for women doctors in academia, and here is a graph showing the number of medical students who were female and male over the years. And I have an arrow pointing at 1966. That is around the time that I decided to become a physician. And at that point, there were about 10% of medical students were women. And so if you look in the 2000s, the numbers evened out, and roughly 50% of students were women. And although this is now the case today, still the academic ladder has the wrong slope for women. It is very difficult to become a professor. If you see this, it's down here. Only 25% of professors are women. The rate for associate professor is also lower than it should be. And for deans and department chairs, only 18% were women. And this is from the State of Women in Academic Medicine 2018 to 2019 from the American Association of Medical Colleges. Just went the wrong way, sorry. What's dual role? So we know that for many of us, we are doctors, we're also mothers, or we're caregivers for older relatives, and this presents a conflict. I just want to point out a study from the Annals of Internal Medicine, I believe it was in 2014, which found that after adjustment for work hours and for the employment status of a spouse, female full-time physician researchers with children said they spent 8.5 additional hours per week on childcare and other domestic activities compared to their male counterparts. Depression is also a diagnosis that affects more women than men, and it is associated with burnout, but it is not the same thing as burnout. And there's a higher prevalence of depression in female physicians, with suicide rates 2-fold higher in women doctors compared to the general population. And the rate of suicide apparently is higher in women doctors compared to male doctors. And these, I just want to make sure everyone understands that this is not the same thing. In one study, although 87% of physicians with depression had symptoms of burnout, of the physicians who had burnout, only 26% were affected with depression. Sexual harassment is the last factor that I'm going to talk about, and this is a picture of a book that recently came out, and I was asked to write a chapter on sexual harassment in this book. And basically, at the end of my article, we said that the overarching question is how to change longstanding social norms that sexualize and objectify women and assume that women and sexual and gender minorities hold inferior status. So we have a long way to go. And it's also important to realize that sexual harassment may be visual or verbal. It does not mean forced sexual conduct, and then it can come from patients, relatives, or friends of patients, colleagues. It does not necessarily have to come from your superiors. And I believe that COVID-19 has had an effect on burnout. And there are, obviously, we all know about the heavy workload. This was a new disease with limited treatment options. There was a loss of control and reduced flexibility, especially during the beginning of the pandemic. There was insufficient PPE and shortage of hospital beds. So we shouldn't ignore the effect of COVID-19 on burnout. And here is a study, a survey of about 1,500 residents and fellows. And what these investigators did is they asked the residents and fellows how many patients they cared for, patients with COVID-19 they cared for in the previous 2 months. And the purple bar is one, this green bar is none, 1 to 30. This lighter green bar is 31 to 60. And this is more than 60 patients. And what we see for emotional exhaustion and depersonalization is that there appear to be greater emotional exhaustion and depersonalization if you cared for the more patients you had with COVID-19. This is shown here as well. So now I'm going to briefly cover some strategies for improving and maintaining wellness and resilience. Solutions to burnout can be thought of as solutions from professional institutions or individual. Well, basically, solution is not really, it's not up to you as an individual to solve burnout, although there's some things you can do to make yourself feel better. But in this National Academy of Medicine paper from 2019, we concluded that the emphasis was on institutional solutions for burnout. So there are potential solutions at an organizational level. Some of these are listed here, and I don't really have time. You can just take a look at them to go over all of them. But one of them, some of them would be implicit bias training and education. Whether that works, we're not sure. Also, safe, clear reporting processes with no retaliation for sexual harassment, equitable and transparent compensation plan, and having sponsors and mentors and leadership training, and a transparent promotion process. So the solution to burnout is with the institution, but as an individual, what we can do is to cultivate our well-being and resilience to help us cope, adapt, and to help us enjoy our life and the career that we've chosen, because medicine, in my view, is a very fulfilling career. So some strategies for improving wellness and resilience are reflection on life priorities and values, mindfulness, positive psychology, physical activity, connecting with others, counseling, stress management training, and laughter. I'm going to talk about a few of these in the next few slides. So this is a slide from my own personal experience. So when things were tough for me as a younger doctor, I would think about why I became a physician and what I valued. And this is just a picture of my dad going on a house call. He inspired me to be a physician. And what he talked to me about was his experience during the polio epidemic in the 1940s. And also I was inspired by the novels of Charles Dickens, because he wrote about social conditions that were extremely poor in 19th century England. And when I was reading these books, I decided I could do something about this if I became a doctor. Here is a slide from my colleague, Dr. Richard Wardrop. He and I have talked about burnout when we were asked by the American College of Physicians to do so. And this points out that positive psychology can help. In fact, negative thinking will never make your life positive. And he also says that gratitude can change everything. So in terms of positive psychology, it's really important to think positively. I used to do this as an exercise. I would try not to have any negative thoughts, even though I had some criticism of things that were going on during the day. And there has been a paper talking about writing down 3 good things every day, that doing this actually makes people feel better about themselves and their experiences. So here is a quote that I really think about. This is from Nora Ephron, which says, "Be the heroine of your life, not the victim. Don't just let things happen to you. Take charge." And sometimes problems are complicated, especially in medicine. And sometimes we do need help. And it's always important to have the courage to ask for help, to keep thinking positively. Laughter, even if it's not spontaneous, is supposed to have positive psychological effects. There's evidence that shows that laughter improves mood, depression, and decreases stress and anxiety. There may be some physiological changes due to laughter, but that needs more research. And so for me, I think this scene, this is dating me, from a movie called Singing in the Rain is very funny. This is when Gene Kelly is dancing, splashing in puddles when it's raining because he's so happy. And this makes me laugh. So I think it's good to have some laughter in your day if possible. Last, I want to point out that it's important to understand the needs of your colleagues. And here is a paper in JAMA in 2020, which on the topic of understanding and addressing the sources of anxiety among healthcare professionals during the COVID-19 pandemic. Finally, connecting with others. This is one of my last slides. These are people from my life. Here is the class of 1949 from Wellesley College in the alumni parade. Susan Lee knows this well. Not that she's from that class, but that she goes to reunion. And these are some of my friends from AMWA. This is my youngest son, my oldest son, myself during my graduation from medical school, and people I went on a hiking trip with. And here is a picture of women doctors at the Medical Women's International Association Centennial Meeting, which was held a few years ago. So very important to connect with others, to share stories, and talk about whatever you would like to. And sometimes I want to end with this. It's very important to find serenity, whether it's mindfulness, yoga. I was looking at a photo, but sometimes we need calm in our lives. So in summary, I've talked about burnout in women doctors, which is characterized by emotional exhaustion, depersonalization, and a sense of reduced accomplishment. I've also talked about factors that impact women that are not as relevant for men. And I want to end by reading off some of these strategies for wellness. Reflect on your priorities and values. Be mindful of your feelings. Pause and take a deep breath when you need to. Practice positive psychology. Focus on your strengths. Keep active physically. Eat healthy foods. Stay connected with family, friends, colleagues. Create new routines and be flexible. Seek counseling when needed. And remember, this is really important, to recognize signs of burnout and stress and help others. So in closing, I want to acknowledge, again, my father, who inspired me to become a doctor, my patients, students, teachers, and colleagues, and especially David, Daniel, and Vanessa, my children, who have always helped me balance my life and my work. And again, I want to thank the New York chapter of the American College of Physicians for inviting me to speak here today. And I want to thank the American Medical Women's Association, who caused me to start thinking about this topic several years ago. Thank you. And if you want to talk to me after this report, contact me by my email, which is shown here. I'm going to stop sharing.
Wow, that was really inspirational. Thank you so much, Dr. Newman. And I loved the pictures, personal pictures that you shared, and the sentiments about staying connected and serenity. And I think that's the thought that we need at this very difficult time. You know, I think one thing I would also amplify is that we are in a profession where we have privilege. And I think we have to remember to be very thankful for that when we're feeling burnt out. Our patients really do share so many things with us, and we are in a place of privilege. So thank you so much. That was really great. And then as a segue to this, we're going to have Dr. Cantonese from Brown, who's going to share her slides and talk about her project in peer mentorship, peer support group, and what she's done at Brown. So super excited to hear about it.
Thank you. I think that, yeah, I totally agree. Dr. Newman, that was a wonderful breakdown. And I think it's such a nice complement to the methods and different versions of peer support groups and peer mentorship that I'll talk about. One of the ways to combat burnout is engagement and meaning in your work. And so hopefully we'll have some ideas on how to incorporate some more of that too. I have no disclosures other than being a woman in medicine. And so I just wanted to talk a little bit about the definition of mentorship, which I think we're all pretty familiar with. But I like the points that are shared here, as I think they outline all the positive things that are gained from a mentoring relationship: collaborative learning, shared responsibility and accountability, fulfillment of clear and mutually defined goals, assistance at specific stages of development, sustained but defined period of time typically, and an opportunity for both mentor and mentee to gain something from it. So some familiar models of mentorship. I think this is the most common one, the dyad. Pros here are that it allows for individualized attention. It's a cultivated relationship and logistically is easy to arrange. Some cons are that there are never enough mentors. Interests may be misaligned or perhaps too aligned, and it really only allows for one point of view. So some other models of mentorship that maybe you're less familiar with, there's coaching, which many of us know about coaching, but maybe not as it pertains to medicine and faculty development. But a coach is basically someone who is slightly more peripheral, who helps their student attain their vision or goal by providing the right tools and mental model. There is sponsoring, which serves to benefit others by way of making a connection. As we continue to promote more equity and representation in medicine at the full professor level, I think this will greatly benefit women in medicine. And group mentoring. So an example of group mentoring might be a program director who is assigned a small cohort of residents for who they offer advice to. Some newer models of mentorship include speed mentoring, which you can imagine in the era of COVID might involve Zoom with breakout rooms, and you might spend 20 minutes trying on different mentors for size. And distance or telementoring. Distance mentoring can offer a unique and refreshing perspective from someone outside of your home institution. It's nice to explore this option when the pool of mentors is small. So what is peer mentoring? There's no universally accepted definition, except that it's usually defined by what it is not. So it's notably different than the dyad and group mentorship in that it's typically a group of people with no formal hierarchy among the individuals. This picture here is of my peer mentoring group that you'll hear a little bit about throughout my talk. We've coined ourselves the Ladies Breakfast Club. And we meet one morning every 1 to 2 months at our favorite restaurant that is conveniently open before 8 a.m. And I'll walk you through some of our evidence-based recommendations for what it means to create a peer mentoring group, as well as sharing some anecdotes and lessons learned from our experiences. So I'll give you a brief run through of some tips here so that you can explore creation of your own peer mentorship group. If you check out our paper that was published last year, you'll see that it's actually 12 tips, but just for the sake of time, I've narrowed it down to 10 today. And this is just a snapshot of the paper, which came out in AIM Perspectives in the Green Journal last May. So tip 1 is to define peer. A peer can simply be someone at your own institution or maybe in your department. You could share clinical interests or the same research techniques. Maybe you want to work with a group of colleagues who share your gender. You don't need to have the same degree. How you define peer is completely up to you. For us, we defined our group as women in the Division of General Internal Medicine at Brown. who were roughly about the same career stage. So when we started, we were all assistant professors, and who share a similar passion for clinical work and medical education. When looking in the literature, other groups have defined peer as a group of junior clinician educators who felt marginalized in a research-focused department in psychiatry. Another example is a cohort of women in junior faculty positions who gather to improve academic achievement. So tip 2 is going to be identifying mutual goals and crafting a mission statement. I love this tip because I think it really helps keep the true north of the group. The mission statement will be your compass and the goals will be your stepping stones along the way. I'll just make a quick plug here for a podcast that I just listened to. I'm sure some or most of you are familiar with Hidden Brain. There was just an episode called Cultivating Your Purpose. And I think it really kind of defines your purpose or your mission statement, and how that's different but equally necessary as having goals. Remember, when creating your goals, use SMART framework, which will be beneficial for expectation setting, and consider short-term versus longer-term goals. Some examples of short-term goals that you might think of for your group might be to redesign the clinic evaluation form at your resident clinic by January 15th of 2022. A longer-term group goal might be to have 3 of your 5 members be recognized for their teaching skills within the next few years. And then you can have individual goals within the group as well. So an individual goal might be to meet requirements for academic promotion to associate professor by the year 2023. So tip 3 is deciding on a membership process, which sounds kind of silly, but it's actually, I think, quite important as we've found. Peer mentoring groups can recruit members in a variety of ways. There can be from 4 people in a group to as many as 12, from what we saw in the literature. Who those first members are is often determined by what prompted the need for the group in the first place. A cautionary tale, I'll say, that we learned here from our group was sort of learning the hard way that adding a 6th member to our group was the breaking point in terms of scheduling. So we found 5 people to really be the sweet spot that allowed for the right amount of input and coordination of calendars. Tip number 4 is set meeting logistics and commit to them. So you'll want to consider the timing of your meetings as well as whether your group will serve a purpose for a finite period of time versus something longer. Other meeting logistics here might include attendance and participation, frequency and length of meetings, and location. There may be compelling reasons to meet at work for your meetings, or equally compelling reasons to not meet at work. So just some of these decisions may be driven by how much time you have in the way of protected time or administrative support, reimbursement, things like that. Tip number 5, set member expectations, roles, and responsibilities and hold each other accountable. So other important things to consider when planning your peer mentoring group will be to think about how you'll communicate with one another between meetings. Will that be email, texting, perhaps the help of an administrative assistant? You'll also want to think about accountability. We recommend revisiting your goals frequently and making them visible and known to all members of the group. And responsibilities, so making sure there's someone in charge of agenda setting and keeping notes. Delineating leadership. So this is a really important decision for the group to make. We see so many different models in the literature, from no set leader at all to rotating leaders, to different leader depending on what the project is, to steering committees, which is what they have used at Vanderbilt in their peer mentoring groups. As far as the Ladies Breakfast Club, we tend to have rotating leadership, which has worked for us depending on the project at hand and the ad hoc needs of the group. Tip number 6 is generating discussion topics. So determining what you're going to talk about is probably the most fun part of planning your peer mentoring group. In the literature, different groups chose different approaches to content. So these are just a few ways you might think of coming up with your talking points. You could do a needs assessment. You can do ad hoc topics versus having a longitudinal curriculum. Or you can set an agenda versus having some free-flowing meetings. I think what's important here is to reflect back on your mission statement, because that's really going to help guide what you need here. So what can peer mentors discuss? Here are a few large topics, and I'll jump into each of these individually to give you some other ideas. So we can start on the top left, general career topics. Preparing for promotion, negotiating salary. How do I ask for a raise, or should I apply for that leadership role? These are questions that your peer mentoring group could be very helpful at. As far as scholarly productivity, that might mean collaborating on research projects together, or having someone critique your papers, things like that. Professional growth. So another area of professional growth might be talking about related books or articles. This could be in the format of a book club, or nominating each other for awards, which is, I think, another highlight of having women in medicine and being honored and appreciated for the work that we do. And then lastly, navigating complexities. So I have listed here processing feedback from trainees or celebrating successes. Sometimes there's not really a good outlet to really process a negative evaluation. So this might be the perfect place to really pick that apart and get some suggestions, thinking about a growth mindset. Tip 7 is going to be asking for support. Support can look like a variety of things. It might mean securing some protected time to have your meetings, having some administrative help for booking meetings or meeting spaces, and it might even mean reimbursement for food and other expenses. So I do want to share one example of a group that really hit the jackpot in terms of departmental support. It's an intensive 1-year peer mentoring model at Cornell that was born from a perceived lack of mentorship within the division. This group was funded by the department and gave participants protected time to attend meetings during the workday. They also brought in an expert facilitator from another university who provided the structure and theoretical framework, as well as evaluation of the program. So this is some place where you can really dream big. Tip 8, recognize when outside expertise is needed. You will likely recognize that there will be times when your group is in need of input that may be beyond the experience of the group members. So that might include someone to help you navigate the IRB, maybe a member from the promotions committee, if that's a goal of yours, someone from conflict mediation. So maybe there's that difficult evaluation or difficult interaction with a colleague. Or maybe you just want to have an admired senior mentor come and be your spirit guide. Tip number 9 is tracking your activities. So tracking activities can be important if you are looking to seek or sustain financial or time support from your division. It can also lead to production of scholarly work. assigning this responsibility to someone in the group can be a very fruitful activity. And lastly, I have tip number 10, which is evaluating your effectiveness. How are you going to know if what you're doing is effective? Is it worth your time? Systematically evaluating the group's effectiveness helps us to know if the group can continue as it is or if adjustments need to be made. And this should be an ongoing process. So with some take-home points, there's growing evidence for many effective peer mentoring models. It's a valuable complement to traditional mentoring models with its own benefits and drawbacks, as hopefully you heard. And then, and I'm hoping that you have somewhat of a blueprint and some references to provide a foundation if you're interested in starting a peer mentoring group yourself. So these are the references. And that is my email and my Twitter handle. If anyone has any questions or wants to share any experiences, I would love to hear from you.
Thank you so much, Dr. Catanese. That was really awesome. I feel like we can start a peer mentoring group right here. I'm going to open the floor up for questions since we have these two experts. We put in the chat the paper that was cited by Dr. Catanese, and we'll be sure to email that to everybody. Does anyone have any questions or comments? Dr. Newman has her hand up.
Yes, hi. That was great, Stephanie, Dr. Catanese. And I just wanted to ask you, in your experience, how large of a group would work? I mean, I know you must know about other peer mentoring groups. So what is the size?
Yeah, there's a bit of variability. The largest that we found in our research was about 12 members. So it does, yeah, and I think anything larger than that, it sort of loses you lose the ability to schedule time together. And I think it's just a little harder to get individual input and things like that. But even for us, I think, as we learned, 5 people was great. 6 was like, the last straw.
Thank you.
For what kinds of goals in your peer mentor group have you tackled?
So a lot of those examples from that grid were actual examples of things that we've discussed. We've had book clubs where, or sort of podcast reviews where we listened to something and gathered as a group. We joke that one of our members, Kate Cahill, she is a huge fan of, is it Laura Vanderkamp, the author, who's very skilled with managing her time. And so we've listened to her podcast and sort of discussed pros and cons of her recommendations. We've had sort of those negative evaluations and where do I go from here? How do I respond to this? Am I supposed to respond to this? Yeah, so a lot of those things were real life examples.
Wow, that's great. I think
we have a
Dr.
question.
Edwards had a question.
Yes, I had a question for Dr. Catanese. How do you measure the effectiveness? You said you look at effectiveness. Do you have kind of secret ballots or what? How do you measure it?
Yes, it's explained a little bit better, and just for the purposes of the talk, I sort of cut a little bit of that out. We haven't, so we track all of our activities and sort of with the idea of one, publishing. So this paper was something that came out of our peer mentoring group, actually. but we haven't used any of the more formal methods of evaluation, but I think a few of them are mentioned in the paper. Some groups have taken it really to extensive levels, and I think have benefited quite a bit from their findings.
Dr. Sagar has a question.
Yes, I guess this question is for both of you. And perhaps maybe Dr. Catanese, you can go first, and then Dr. Newman, you can give us your thoughts. One of the things I find that's a common concern, whether it's a peer mentoring group or it is discussion about conflict or difficulties in coping with multiple responsibilities, work and life integration. The concern is confidentiality, and like, will you be able to seek that assistance? And I guess Dr. Catanese, like, in your peer mentoring group, do you guys kind of say, okay, everything remains confidential? Like, how do you tackle that? And I guess Dr. Newman, what would be your advice for women who do want to come forward to discuss burnout and other concerns?
Yeah, that's a great question. I think I think falling back on the mission statement can be helpful here. I think that's a really important thing, and with an eye towards, like, all right, what are we hoping to learn from this person's experience, and like what kind of help are they looking for? I think is extremely important. That kind of stuff has come up in our peer mentoring group, and it is like, a sort of unofficial safe space. We have a psychologist that works in our division, mostly with our house staff. We've had her join us as an expert to just talk about lessons learned during COVID, and like, how do we process the things that we've seen, the additional burdens and responsibilities that are placed on us. So that was one thing that worked for us, was like bringing in sort of an expert to address our needs.
Okay, do you want me to answer? This is something that I just thought of because I'm a member of a number of groups, boards, for example. And I don't know how this would look, but I think if it's in such a group, I think it might be possible to write up a description of the group and its mission, and a statement, and then at the end to say that everything discussed here must be confidential. So people would actually read that. Now, whether you want them to sign that is another step. But that makes it, I mean, if that's done at the outset, perhaps, that's just a thought. I don't know how people would perceive that.
I think that's very helpful from both of you, because while you could definitely have that discussion, but also perhaps some women may feel more comfortable if it's on the outset, very clearly stated. Thank you.
Our women in the group that Dr. Lee mentioned earlier, we have a lot of very personal conversations online in that group, and the group is limited to certain people. We have to check their credentials, and everyone knows that they must keep it confidential.
Yeah, there's over 2,000 alums in this group, and we have certain rules. You can't take screenshots and share them, and it's very private, and people have respected that. And people ask, it's a really great group because it's not only undergraduates, but it's attendings, it's senior physicians, and people ask about career advice, and it's a very safe space that Dr. Newman created. And everyone's pretty much vetted. I don't know who does the vetting, Connie, but that's got to be a big
There's a
job.
small group of us. There's a 3 people. We do the vetting.
It's got to be a big job.
You have
So,
to be accepted by us to join.
yeah. But for me, it's been, like when I was, I'm a dual career parent. Like, how do you manage the challenges of work and taking care of your children? And I know I asked questions and people were able to answer them for me. So that was a good space for me. And that helped me to combat issues of burnout. I kind of wish I had this peer mentoring group early on when I started at it's a great idea. I think the other thing that Dr. Newman mentioned, and maybe you want to expand on that, is about the importance of having laughter and interests outside of medicine. I think that's really important. So maybe a peer mentorship group could be like a hobby type situation.
Yeah, thanks. I think that's a good idea. I feel fortunate that I'm able to laugh like every day because of my husband who makes me laugh. But I really think it's important to have outside hobbies, and I certainly do. And when my children were younger, I didn't have time, and I know for many, but I think it's important to try to fit something in to take your mind away from your daily work.
I see Dr. Anandu on the call. I think she leads one of our peer mentoring groups. Do you want to talk about it?
You mean through ACP or?
Or I guess through NHPP or ACP?
Oh, yeah. Yeah, so I help with the Connect the Docs program for Northwell. And I also help with one of these affinity groups for Northwell too. Connect the Docs is a dinner program that people from a certain region can meet at a restaurant, and we just have dinner together. You know, there's no set agenda, there's no speaker. There's some speaking prompts that are along the lines of wellness, but usually the conversation is very organic, and it's a great way to meet people outside of our silos. And then the affinity group through Northwell is where we meet through a mutual interest, whether it's book club, gardening. Somehow the most popular groups have been the wine club and the whiskey group. So, and I think a lot of that has to do with us being so distant with the Zoom. It was the easiest way. But it's been great. It's nice to connect. I think for me, that's one of the best things to help mitigate burnout, is to just connect with others. There's so much support in that. And Dr. Segar, you have to join one of the groups one of these days. They're a lot of fun.
I do. I sign up and I'm guilty. I'm guilty, definitely.
Let's see. Are there any other questions? Seeing that there are none, we have ended on time and we had a great program. Thank you to our speakers, and thank you to Karen for organizing and pushing out the emails and coordinating the Zoom. I hope you will join us. When is our next date? I don't even, is it, it's in the fall, October, correct? And so that should be a really good way. I think it's our social media one, right? So which should be, I know a couple of us are on Twitter and such. So that should be really exciting. But thank you everyone for joining. I feel so much well just moderating this program. And Dr. Catanese, you are welcome to be in our chapter.
Thank you so much.
Everybody.
Thanks, everybody.
Yeah, this was lovely. I had a great time. Thanks for the invite, and thanks for thinking of me.
It was great having you. Thank you for your time.
Thank you.
Yeah, thanks.
Thank
everybody.
you.
I want to thank
for next meeting.
I want to thank everyone for giving us the opportunity to talk.
Thank
I
you.
learned a lot from Dr. Catanise's session.
Likewise, thank you.
So everyone stay safe. Karen, can we send the slides to the attendees?
I am recording the session and happy to send the link, and we're going to post on our website. And just as I was trying to say, November 9th is our next meeting. So I will be posting information on that shortly too. So we're all excited for part 5 of Women in Medicine.
Okay, great. Thank you so much.
Okay.
All right. Good night, everybody. Stay
Good
safe.
night.